I want to say thank you, everyone, to have joined us today on the call. Today we have Angela, who's going to present to us on the complex care initiative or service at the IWK. So I think this is quite exciting given the fact that we will have had presentation from team members from really across the country since the COP has started. So Angela is a graduate of Humber College, and she completed her Bachelor in Nursing at the University of Western Sydney in Australia, and I believe in Kenyon College as well in USA. And she's completed there her Master of Science in Nursing in 2006. So over the past 16 years, Angela has joined a position in Canada, and you can let us know where you're at, Angela. Welcome.
Thank you. Gosh, I just realized that bio is a little bit old. I'm up to almost 20 years in nursing and feeling every year of it right now. So today, thank you so much for asking me to share what we're doing here in Halifax. I just thought I'd give you a little rundown about our health center and what we're doing. So this is what we look like in the summer, or maybe in the fall because the colors are changing, but this is our health center. We are a tertiary health center for women's and children's health for the Maritime provinces, so that's for New Brunswick, PEI, and Nova Scotia. And so this side is our women's side, and this is our children's side, and then we have some shared services here. So we've been around for quite a few years, and we just keep growing. So like I said, the IWK is the tertiary center, and just to give you a little bit of background, in January 2014, the population of Nova Scotia was 940,592 people. So basically, you can fit the population of Nova Scotia into the GTA. 60% of our population is rural, and Halifax, or the Halifax Regional Municipality, is our major urban center. And that's highlighted in the yellow here. So you can see we're spread out quite far. And we do provide services to Prince Edward Island and New Brunswick as well. So really, we don't have a formal program here at the IWK, but we are grounded in chronic illness theory. And we do have a model of care that has evolved over the last 10 years to meet the changing needs of our patients and families and our community, as well as the changes in healthcare in Nova Scotia and in Canada. A few years ago, well, more than a few years ago, 10 years ago when I started this position, I was a clinical nurse specialist for kids with chronic illnesses. And over the last 10 years, that's really been narrowed down to our complex and medically fragile kids. Pretty much, there's a team that surrounds your typical chronic illness populations like CF and diabetes, but there was nothing for the kids that didn't fall into any particular pigeonhole. So a couple years ago, my colleague and I developed some inclusion criteria for getting the clinical nurse specialists involved in some of our complex kids, but it also is a good outline of our inclusion criteria for this population in general. So what we're looking at is, in general, the kids have more than 3 organ systems involved, or have one system that's severely involved. Have 3 or more subspecialists, and it's pretty much as soon as you've got 3 on board, you're complex. The diagnosis is unknown or uncertain. If the kids have had more than 3 admissions in the previous year with a length of stay of greater than 5 days, and have had or have the potential for more than 10 clinic or emergency room visits per year. Lived experience of kids who are medically fragile here in Nova Scotia. And then, of course, if they're dependent on technology or dependent on others for their activities of daily living relative to their developmental stage. The reason we included the activities of daily living in the complexity criteria is because that is one thing that was a challenge when trying to get kids home and getting home care support, is that that criteria, or that the inability to perform your own activities of daily living was a big criteria for the adult population to get home care supports, and we didn't really think of it for the children, but also the activities of daily living for our complex population, we feel includes things like and some of those medical skills, so it kind of helps marry the two populations together, the adults and the pediatrics. So we have a very multidisciplinary approach when we look at these populations. Quite often the kids start off in our neonatal ICU, and we work at doing a very coordinated handover when the kids transition from NICU to the Pediatric Medical Unit, or PMU, you'll hear me describe it as. And we tend to have a couple of meetings with the physicians, social work, discharge planners, nursing, allied health, to get a really good sense of what this family's situation is before we transfer them to PMU, so we don't waste time or spend time talking about things that we could have done previously. On our medical unit, we have two resident teams of learners. We have a large team and a smaller team, and the smaller team tends to focus on these more medically complex patients, and that is something that historically just always existed, and now we just exploit it. We have the main pediatrician who manages that team has always had a keen interest in the more complicated patients, more complex patients, so we just kind of ran with that. The larger learning team, they tend to change very quickly. Our staff physician changes every 2 weeks, and so having a smaller, more focused team where the pediatrician stays on for a longer period of time really helps smooth any transition and decreases a lot of repetition or redoing of things that have already been tried and tested. I provide case management, or my colleague provides case management. We do have family meetings every 2 weeks with the team just to make sure that we have ongoing communication and that there's a real openness and transparency to what we're doing. And for our clients and patients who are not from Nova Scotia, so are from PEI or New Brunswick, we have liaison nurses who are stationed here in Halifax. They are Nova Scotian nurses, but their area of expertise is the other provinces and what those health systems are like and what sort of supports are available, and they are absolutely invaluable. The boxes that you see on the right just highlight some of our multidisciplinary team, and I like to brag that we have a music therapist. He's only part-time, but we love him to death. So our discharge planning process is a huge amount of assessments. Again, it's interdisciplinary. There's a piece for nursing that is a review of systems and medical needs and actually gives us some points or scoring to help emphasize the amount of support that the family needs. We look at family supports and respite needs, pharmacare, health insurance, those sorts of things. And one of the big kickers, especially in Nova Scotia, and I know this applies anywhere, but having a child who is medically fragile has a huge impact on income. And in Nova Scotia, we have a large population of seasonal workers. So those are your basically they're fishermen, and when they have the off-season. Some can't fish in the winter, some do fish in the winter. It's very seasonal, and it's very, very common for families to either split up or lose their jobs because they've had a child in hospital for so long and a huge reduction in income. If they were a two-family income at the get-go, rarely does that maintain, and it's just a matter of the way life is down here, especially if you have seasonal employment. I thought I'd take a minute and show you a couple of our tools that we've developed over the last couple of years to help us with this population. So this first one, it'll just pop up. So this is, we called it our clinical pathway for the complex and medically fragile children and youth, and you'll see the criteria that I showed you earlier. And this is just a basic map of what we expect to happen over the length of stay of the kids. So without trying to put any solid dates on it, usually on day one is our transfer day or admission day. We figure out which CNS is following the family, talk to the family about how they want to participate in our daily rounds, the inpatient unit routine, and then from there we set up our care plan, how we're going to communicate. Some families want weekly meetings, most want bi-weekly, they're happy with that, and sometimes they spread out to monthly depending on how things are going. And we really, under communication, we really try to link early with the family doctor or community-based pediatrician to bring them into the circle of care early on. And also with our community-based supports. So I've got early intervention and healthy beginnings. Healthy Beginnings is a program through our public health, nursing, and early intervention is your progress center. There's usually a lot of teaching and education needed, so we're looking at days 5 to 10 from there, and then our discharge planning that happens pretty much from the beginning. And we've highlighted the things that tend to be our biggest problems. So funding for respite and equipment and home care, and just leading up to discharge. The second one is our patient. Oh, please pop up. There we go. Is a more comprehensive but incredibly long discharge summary. And what it provides, this is something I found from England, from the UK, that they use to assess their patients. And it really goes through kind of who your team is, and then sorry for going so quickly here, every area or specialty has their assessment form. So there's one for pharmacy and medicine, social work, and just really provides a home for all the information. And as you've probably figured out, we don't have electronic charting down here yet, so we're still very paper-based. This provides a really nice way that we can have the team put all their information together, and then we can send this electronically through email to home hospital or whoever's providing the home support to the family in advance of that discharge summary. Discharge summaries can take upwards of 6 weeks to be transcribed, and that's not really helpful for our home-based or community-based clinicians if they're waiting 6 weeks and the patient's on their doorstep tomorrow. So it's just a big long document. I'm just going to skip through to show you the nursing section, which is the longest one. So as you can see here, it's broken down by systems, and then there's a score applied to it. And again, this was adapted directly from England, so we didn't really change much about it as far as scoring and that sort of thing. But it's really helped us figure out, how many hours of home support they're going to need or would be helpful. In the past, it was just an ask, like, oh, how much respite would you like? Oh, I'd like 24/7 respite. And people would try and get that, and that's just not realistic. We also have this sheet that we use, and it's basically just a bunch of boxes that grow as people write in them. And the resident team uses this to facilitate that really long discharge summary that's going to happen. So our length of stay for our really complex kids can be upwards of a year. So this helps the teams over time kind of look at what's been done, what we've tried, if there were medications that were tried, why we tried them, why we discontinued them, again, to try to reduce complications, or at least to look back and say, or to reduce repetition, or at least to look back and say, oh yeah, we have done that, oh, it was a while ago, let's try it again, that sort of thing. And the residents are finding that when they do use this, it really helps them with their discharge summary and with their handover, so they can just update as they go. And then this is another tool that we're using, again, it's in draft form from November, to help facilitate communication on the inpatient units, but also to just, I like lists, and it's come to my attention that people don't read progress notes anymore, and so if we have something that's on the chart that it's all in one place where people are saying, oh, you know, do we know if they have insurance, instead of someone trying to go through a thin chart to find the social work note that says, yes, they do, it's right there. So this kind of grew from a whole bunch of issues of discharges that were considered kind of messy or not so comprehensive. So we came up with this big long list of what we need to know and how are we going to communicate that to our colleagues across the province and interprovincially, what kind of support do they need in order to provide care. In Nova Scotia, like I said, we have tertiary centers and then the rest are regional. So the majority of our regional hospitals that have pediatric units, it might be 4 or 5 beds that's tagged on to the maternal child unit, or 1 or 2 beds that's tagged on to the maternal child unit. The majority of those beds are used for overflow for adult surgeries, so the amount of inpatient or skilled care that the pediatric kids are going to need, the regional hospitals aren't as familiar with. So a lot of times discharge or home care is really challenging because the level of expertise just resides in the HRM. It doesn't reside throughout the province. So one of our biggest issues is funding and more funding. So when we're looking at the durable medical equipment, we look to health insurance first, but generally you either have or you don't have. And then we're looking at service clubs and charities, income assistance programs, and we do have a couple of provincial programs that can help cover the cost. For our really complex kids, especially our complex respiratory population, we're looking at asking for exceptional funding from our home care, which is called continuing care in Nova Scotia. So we're actually asking for above and beyond what the province has allocated for home care. Our follow-up in ambulatory is generally coordinated visits. We don't have a specific spot for a complex care follow-up clinic. Our pediatricians in our clinic area do tend to do a multidisciplinary clinic maybe once a month for their patients. Some of the clinics are co-located, but they're all pretty much within a really quick walking distance. We're a smaller hospital. For our out-of-province patients, there are some clinics that do traveling clinics, so cardiology and ophthalmology will go out, so that might be an option for them. And we really try to tailor their follow-up to what they need. So some families like to come in, get everything done in one day and go, and others would like to travel to Halifax, stay at Ronald McDonald House for a week, and move on. Our home care, like I said, is called continuing care here for our complex respiratory patients, and these are kids with trachs and or trachs and vents, or CPAP and BiPAP. We have managed to work with some home care agencies for a continuing care assistant or a personal support worker level of care overnight in the family home so the parents can sleep. Parents will remain the decision makers, and this is where those activities of daily living tie back in. The CCAs receive the patient-specific training on the ADLs, and that includes suctioning, oxygen administration, that sort of thing. So we looked at their scope of practice and tried to not manipulate it, but actually work within the confines of their scope of practice to explain what is an ADL for a complex or medically fragile kid. There's one specific agency in Halifax that we work with to provide the CCAs because they were the most willing to step outside the box. And for some of our families, we're able to get about 10 hours a week of daytime respite through our VON, and that's something that's standard through continuing care. The other big group we have is our home TPN program. There is a provincial program that's funded for home TPN. However, it is designed and the budget is for adults, so we try to squeeze the pediatric patients in. And because the care is different, we usually blow their budget with one peds patient. There was no additional money put forth for the pediatric patients, so it's usually operates in a deficit. It covers the cost of TPN and IV equipment. We loan our spark pumps to the families from the hospital. There is no respite support. It's quite challenging, and we usually end up working with the regional hospital for central line dressing changes and emergency planning. Our other populations that are relatively complex but kind of have their own programs other than CF and diabetes, the hematology, oncology, and nephrology services, and HEMONC uses a family care coordinator model, and the nephrology patients are managed by a clinical nurse specialist, and the parents are taught to do home dialysis. And our neurology population, mainly the complex seizure disorders, the neurology clinic nurse manages those kids, and our neuroresponse team manages the brain injury population. So our big challenges in Nova Scotia and in the Maritimes is a real lack of provincial programs to meet the needs of children and youth, and again, there's the square peg in the round hole. We have a small number spread across the provinces. We found some huge challenges with insurance companies, especially if the children are born here and the family does not get them on their insurance plan within the first 30 days. The children are then deemed to have a pre-existing medical condition and do not qualify for insurance. There's a huge amount of fear and uncertainty in our regional centers and out in the community. We don't deal with kids. Kids are scary. And I'm sure this is all ringing bells for you guys. Big needs, big costs, and a small population. And right now, the province of Nova Scotia is undergoing a huge transition in healthcare. We were divided up into 9 district health authorities, so everyone did their thing in their area, and now we're transitioning to a single health authority for the province, which is causing a lot of stress for the rural communities as it's changing how the management structure is, how things are set up, and where their budgets are going. So it's just one more thing to have to work with. On the positive side, we have worked with our continuing care colleagues to develop a pediatric assessment tool. A lot of the CCACs or the continuing care home care folks have a computer program with a pediatric module. Nova Scotia did not purchase that pediatric module, so we came up with our own. And we've been working, like I said, with the home communities on a case-by-case basis. I don't know how that's going to look in the future where we go to one big provincial health authority. So again, I'll just leave you with this picture because you don't want to see what's outside my window right now. You can contact me or my colleague, Rebecca. We job share, and hopefully in a few months we will look like that. That's Halifax Harbor, and it's much better than the 6 feet of snow I'm looking at right now. Are there any questions?
This is Lisa. I'd just like to thank you, Angela, for that. It was great. I just was wondering, how many, when you said, you know, it's a small population out there for sure, but how many kids do you think come through there that fall in under your criteria?
Where's my list? So right now I have 11 kids on my caseload that are active in this program, and I think my colleague has probably about the same. So we're looking at about 15 to 20. The oldest one is 18, and the youngest one is 2 months. So it'll be consistent. It seems to increase every year. And the more technology that becomes available, the bigger my caseloads get.
Hi, it's Natalie.
Hi.
Thank you very much, Angela. This was a great presentation. Do you guys offer like continuity when you become the coordinator? Do you do this long term? And the second question is, do you maintain ongoing contact with the community physician? Because as these kids are complex and fragile, they tend to be more in the hospital. So I just want to find out from you, how much involved are the community physicians?
Yeah, so yes, once the kids fall under our program or whatever you want to call it, they're stuck with me until they don't want me anymore, or until we transition them to adult care. Keeping in touch with the community physicians is easier in the Halifax area because, again, it's a small number and the majority of them come to the hospital. I find that the ones that are more rural, we're getting better with doing telehealth throughout the client's stay in hospital. That's something kind of new. Instead of just being caught up in our own little world, we do try to do telehealth throughout their stay so that they're up to speed, and that when there is a discharge and ready to go, everyone is totally prepared, but it's still a work in progress.
Okay. So do you use much the telehealth? Because that's a great...
Yes. Yes, we are high users of telehealth, especially when we have you know, families from northern New Brunswick, so up by the Quebec border, and we're hanging down close to Maine. It's really helpful.
Does anybody else have any questions or comments? Or
I have a quick comment, Preeti, from PCMCH. I think this is a great presentation, and it's really resonating with me because of the work that we're trying to do provincially here in Ontario. And the things that really stuck out for me were that interprofessional patient summary. Right now we're trying to develop a paper-based shared care plan for integrated care teams that focus on children with medical complexity as part of our long-term goal to create a province-wide electronic care plan. And I saw that some of the things that you had in that patient summary were really interesting, and I'm wondering, I can connect with you, Angela, offline, but it'd be great to, if possible, get a copy of that to see it.
Absolutely.
And then the other thing was the thing you talked about with the coordinated visits. We've hosted a task force meeting with senior leadership of the pediatric hospitals in Ontario for them to start to think about how can they start to streamline clinical visits for children with medical complexity, given that they can have up to 11 subspecialists and multiple appointments, and they're traveling back, the families are traveling back and forth for these appointments, which is a huge emotional and economic burden for them. So if you have anything related to the work that you're doing there, that would also be great to see. And just wondering, how have you started to tackle this issue?
So a couple of things. So we do use an electronic booking system for our clinic visits. So it's it's called community-wide scheduling. So you can actually go in and look and see when people are coming in for visits, when things are scheduled, or when physicians have clinics. But I think the biggest piece is that it's a lot of legwork.
Mm-hmm.
The benefit is we're small. So
Right.
I can send an email to 7 people and say, I need to bring this kid back, from New Brunswick or locally, and they need to see all of you over 3 days, go, and people will actually just go and coordinate. So it's a lot of it is just the mindset and the sense of community in our center, where I can just say, oh my gosh, guys, we need to do this, and we can do it. So a lot of it is people skills, and the fact that, yes, I can go in and say, oh, look, they're going to be seeing, orthopedics on this day, and the pediatrician may say, well, I'll just run down there and go see them then.
Right.
So I don't have
no,
any
it definitely
magic.
helps. Yeah, no, I see what you're saying there. Yeah.
Yeah, so for the most, it's a lot of it is who you know.
Mm-hmm.
And it helps that our clinics are all, like I said, on the same floor pretty much. We're spread over 2 floors, so it's kind of hard for them not to say yes.
Right. No, but thank you for this presentation. It was great.
You're welcome.
Hi, Angela. It's Natalie. I have another question for you. Do you guys have a vented patient in the community? And by vented, I want to specify, I see them as 2 groups. There's the non-invasive ventilation and the invasive ventilation. And if you do, what kind of requirements or what does your community offer in terms of number of hours of support for these families?
Right. Yes, we have both, so the non-invasive and the invasive. Right now we have 1, 2, 3 children who are ventilator dependent. And this is where our assessment sheet really helps to help push the need for the support. So of those 3 cases, we have 3 different setups for support. So the one family has 24/7 support, and that's set up through their insurance and through a home care company, and it's paid for through the insurance. So they managed to develop a mixed bag of RN, LPN, and CCA or PSW support for 24/7 care. Another client who is only on her ventilator at night, but she is totally dependent on it, and she has 4 hours of 8-hour nights a week. And then my third person has 7 nights of 8-hour support. So it's all different, and it was really based on a lot of it was family advocacy and how much they could advocate for in their own communities. We offered up to provide the training and support that was needed, and that's kind of how we ended up that way. But yeah, it's like doing it over every time. Every case is different, but we're trying to standardize things so that it is more equitable. Does that answer your question?
Yes, no, thank you.
Hi, Angela. Can you hear me?
Yep.
Okay, it's Rose Francis from McMaster Hospital in Hamilton. And just wondering, do you follow the kids then as a CNS? Do you get to see the kids back in clinic with one of the pediatricians from the hospital?
Yep.
Okay.
Yeah, I'll go to clinic visits. I do a lot of home visits.
Okay.
Yeah, it's great.
And do you have like a one designated pediatrician then?
Nope.
From the hospital, or?
I have 7.
So one of 7 will take on?
Yep.
Okay.
Generally, they do. One of our pediatricians, it does tend to focus a little bit more on the complex kids, but now that he's starting to look towards retirement, the other pediatricians are all starting to slowly take them on. So
okay. And just kind of divide them up between
Divide
them?
and conquer, yeah.
Divide and conquer, okay. Super.
And then
you.
that leaves Rebecca and I as the consistent.
Sure, of course. That's great. Thank you.
Angela, to Elaine, I no questions, just a comment. The presentation was excellent. Just thank you for bringing that to us.
My pleasure.
So thank you again, Angela. I think we will move on with our agenda. So